ಆನ್ ಮಾಡಬೇಕಾ? ಆಗಿದೆಯಾ?
ಆನ್ ಆಗಿದೆ ಅನ್ಸುತ್ತೆ.
ಇಲ್ಲ, ಅಲ್ಲಿ ರೆಡ್ ಇದ್ರೆ. ಹಲೋ. ಯಾ. Karthik, good to go? Let's start. Let's not delay the proceedings. Yeah, good morning, everyone. Yeah, it's quite an informal gathering over here, I guess. Only the speakers and the moderator and the panelists are there. Good for us. So we'll have a good focused discussion. First of all, I think Dr. Lalit Verma is probably not making it in time. So we'll skip his talk, which would have been very informative. So we'll go to probably, I don't want to say it in terms of hierarchy, but the next most senior most person, Dr. Praveen. And yeah, I mean, yeah, Dr. Kumar is equally experienced. Both of you are legends of Retina, and as far as Karnataka is concerned, I'm sure. We all look up to you, sir. Over to you. Thank you. I would request the panelists.
Very good morning, and I'm talking about combined phaco with vitrectomy. So the indications for this kind of a combined surgery is when there is a cataract coexistent with the retinal pathology, which can be addressed surgically. Also, when we anticipate a progression of the cataract post-vitrectomy, sometimes a surgeon may take a decision to operate both together. You may also think of combining cataract with vitrectomy when there is a clear lens, but when there is a lot of anterior retinal pathology which needs to be addressed, and where you fear that you may end up touching the lens, and therefore you might electively try to remove the lens and then go ahead with the surgery. Of course, when you have an accidental lens touch, then you will combine a cataract with a vitrectomy. And also the event where you are doing a phaco and you have a PC rent and a nucleus drop or an IOL drop, then you combine it. If you have a vitreoretinal surgeon, or if the surgeon is capable of doing both, then you will combine both and do it. So what are the challenges when we take this step? So one, of course, is the longer duration of the surgery. So the longer duration will result in epithelial edema, poor viewing for the retinal surgeon. The pupil may go down in size. So as retinal surgeons, when we are operating with a phacosurgeon, we request them to do a surgery as fast as possible, try to keep the pupil as dilated as possible through the surgery. The second challenge is the loss of barrier function. So this is a very important thing when we are operating on proliferative diabetic retinopathies, because sometimes rubiosis and other things can be precipitated by the decision to do the cataract along with a vitrectomy. The third challenge is the power calculation of the IOL. Sometimes a taut posterior hyaloid may give a spike, which may give us a wrong IOL number, or a detached retina may make it difficult for us to decide on what's the IOL power. And the fourth thing is the use of tamponading agents. Sometimes if you have a hydrophilic acrylic lens, you may find that it is difficult to use gas, or you may end up having a discoloration of the lens. But still, combined surgeries are becoming popular because you have better phaco machines and you have better vitrectomy machines. And small gauge vitrectomy has made a big difference in the capability of what we can do. And we have much better viewing systems. So hence, we use it more often. I tend to use it quite often. So one of the things which I wanted to show is in a situation where you have to do a cataract with a vitrectomy, you can use the endoilluminator to give you a good red reflex. Sometimes if there's a vitreous hemorrhage, it may preclude your red reflex, but having a endoilluminator inside gives you a much better view, and you can do your rexis very comfortably. using the glow from the endo-illuminator. So I have just shown one typical case where I try to have the 3 ports before I do the cataract. So this is because the eye is firm and I can easily put my ports, and thereafter proceed with the cataract surgery. So the cataract surgery, I tend to have a slightly larger rhexis when I do a combined this thing than my traditional rhexis. The infusion at this point of time is off. So the standard phacoemulsification you follow. Only thing is, when you're doing the phaco, sometimes if you don't have your plugs in place, or if there's a leaky valve, you may find that the AC deepens a lot. So we try to avoid that. We try to keep the intraocular pressure lower so that we don't have too much of fluctuations of pressure which can cause the pupil to come down during the surgery. So with standard direct chop technique, I remove the cataract. And once we have washed this thing, you note that the pupil is still maintained. So we use viscoelastic periodically so that we don't have the fluctuation in the pupil size. Try to maintain it as much as possible. Use adrenaline to keep the pupil dilated. And try to not touch the iris during the cataract surgery. So these are some of the small tips that you can take to avoid the pupil coming down. Many times, even though the pupil may come down, once we start the infusion, it tends to redilate once again. So all is not lost if something like that happens. Now the last step is washing out the viscoelastic. It's very important. I'll take half a minute more to remove all the air bubbles which may be there, because the small air bubble sitting in the center will make viewing very difficult while we are trying to do the vitrectomy. And once we hydrate the wounds after removal, we go in with the vitrectomy. So this is a case where there was an epiretinal membrane along with the cataract. So we are able to do a much better anterior vitrectomy in a pseudophakic eye. You can vitreous right behind the posterior capsule. And the small air bubble which may come in can be a guide to tell you where your posterior capsule starts. And you do a thorough vitrectomy and clear the peripheral vitreous. And finally, I use brilliant blue-green to delineate the membrane. You can see there's a OCT also, which is telling us that there is a ERM. But when you put the stain, so I stain directly under saline. So there is a negative staining. So the ILM takes up stain, but the ERM doesn't, and that gives us a clue. And you can see that the membrane is much larger than what we expected. So closure, and generally this is how we combine phaco with vitrectomy. I won't go into my second case. So thank you very much.
Thank you, Dr. Praveen. I would request Dr. Monica to start a presentation. In the meanwhile, we can probably take 1 or 2 questions. Panelists, do you have anything in mind?
2, 3 things that I request or I do is have a slightly longer tunnel, so it helps in keeping it stable, especially when we are depressing the eyeball intraoperatively. Second is to have a smaller rhexis so that the IOL doesn't prolapse, especially if we use gas intraoperatively. And I have stopped using a Midriatic at the end of the surgery. It has at least reduced the chances of the IOL decentering in the one or first post-op day. So these are 2-3 things that I do or I request.
So,
Yeah, minimal. You can, it doesn't come to the center. I hardly ever do. If I have a posterior capsule, I don't do a PI. If in case we don't have an intact posterior capsule, in that situation I may consider. In a rare situation, if I'm using gas and then a bit of the gas comes to the front, okay, inadvertently through the weak sonules. In that situation, I may plan to do a inferior PI at the end of the procedure. I recently had a case where an oil bubble came into the AC, and that's been bothering me now for quite a few days because that bubble is moderately big, and it's also buggering up his entire vision because of the refractive element it's causing in front. Often I don't use a suture, but in a rare situation, if it is leaking or something, I don't hesitate. Suturing is not something which I will avoid if it is required.
At the end of the surgery, do you take it out? Because we have seen that it causes congestion and later on the diabetes is uncontrolled. When you try taking out it in risk of end of.
Correct. No, I leave 10-0 if I feel it is required.
I feel the information is more into the combined surgery. What happens now with this, you fill with gas or oil. Now there is no space for the inflammatories to go into the vitreous, so all will come into the anterior chamber and it will cause a synechia. And
Yeah,
so
the incidence of synechia is a little more. I haven't found it a big problem in my series. And the issue is that if you can do a vitrectomy without doing the cataract, it is still the gold standard. So no one should go off with a message that every cataract should be removed or every lens should be removed. The dictum, which is what we learned, which is still true, is to keep the lens, do the vitrectomy. So in an ideal situation, but we don't live in an ideal world. So the patient wants a quick fix.
Okay.
So they have primarily come for a cataract and you find an ERM or a macular hole. So then do you want to address it at the same time? So these are the situations where we have to take a decision. And each time we should use the judgment. If it is possible to avoid, if the patient can understand, it's better to do it separately.
yes, sir. Two-stage procedure.
Two-stage procedure.
one last question so that we can move on to the next speaker, sir. You talked about anticipation of cataract progression. What are the tips that you can give so that these are the signs that, okay, this cataract might progress?
No, in every vitrectomy, the cataract is going to progress a little faster than what is there. But if you have an early posterior subcapsular which is starting a speck or something, that may move faster. And if you have a lot of cortical opacities, they may progress faster. Nuclear sclerosis becomes more evident, especially surgery. If you are likely to use gas, it's again a situation where your cataract may progress much faster. If it is going to be a very long surgery, again, that's a situation where even as you are doing the surgery, you develop some of these feathery opacities. Some of them clear up post-operatively, but if you end up using gas, you may find that the cataract progresses.
Sure, sir. Thank you.
So if you're doing a sequential cataract and a vitrectomy, not combining the both,
Generally, I prefer about 6 to 8 weeks minimum.
8 weeks. Okay.
And if there's an inadvertent lens touch,
Yeah. So most of the situations, if you have a backup lens, this thing, then if you have measured it, you can take it up on the same sitting. If you have not done that, it may be better to complete your retinal surgery if you can, go back and do your cataract.
All right. I think cataract, anything related to cataract, there will be questions all over. But we'll still go ahead with the next one, which is again something related to cataract surgery, intravitreal injections before cataract surgery. Dr. Monica, she is at Netradama as we see. Uh, Welcome, and yeah, please go ahead with the present.
Okay. Good morning, everybody. First of all, I'd like to thank the organizing team and the scientific committee for giving me this opportunity. So I'll just start with my topic. Intravitreal injections have been proven to be efficacious in treatment of various vascular and exudative diseases like AMD, RVO, diabetic maculopathy. When combined with cataract surgeries, they improve surgical outcomes in such diseased retinas. Now, before taking up a patient, we must definitely do a very comprehensive examination of vision slit lamp examination, see whether the cataract grade is matching with the visual acuity and the fundus findings, and rule out neovascular glaucoma, NVI, and if possible, always do a OCT in such cases. Now, macular edema can be as gross as this or subtle like these cases, and varying grades of macular edema can be seen on OCT, according to which we will decide our treatment plans. Indication for perioperative therapy could be in pre-existing retinal pathology patients who are being previously treated for wet AMD, DME, and vascular occlusions, or we are detecting it at the time of just before a cataract evaluation on clinical examination or OCT. In such cases, we need to give a combined treatment and decide when should we intervene with the intravitreal injections. We should in fact do before the surgery in case of moderate to severe edemas. Previously, any sort of untreated macular edema or CNVM lesions which have not been stabilized, and ideal time would be at least 2 weeks before the cataract surgery. We can also combine it with the cataract procedure in previously treated now stable patients, or previously treated patients who are having persistent edema with maximal treatment, and also in cases of preparatory cataracts, say before vitrectomy, or if we have planned the patient for a PRP post cataract surgery. Amongst the intravitreal pharmacotherapeutic agents, we have the option of intravitreal steroids and anti-VEGFs. In steroids, we have triamcinolone 4 milligram. Dexamethasone 0.7 is the most commonly used as Ozurdex. Anti-VEGF, we have an whole list of anti-VEGFs that is available. Now, which one to give? This is not, there are no rules regarding this, and it's more like a preferred practice pattern. Anti-VEGFs are usually preferred in previously untreated cases, in steroid responders, NVG of course, wet AMD, and even in cases of unlasered vascular occlusions or PDR cases where there may be progression of edema and the avascular status. Steroids are generally preferred in patients who require multiple intravitreal injections. They have recurrent or recalcitrant edema, especially previously lasered patients, and they may be preferred in patients with recent MI stroke. Now, amongst the different type of anti-VEGFs, we have good evidence regarding the use of bevacizumab, ranibizumab, and aflibercept in real case studies and trials as well, using them in cataract and perioperatively, but not much evidence regarding brolucizumab and faricimab. Coming to contraindications of anti-VEGF, mainly it would be recent MI or stroke or any other thromboembolic phenomena. Avoid in cases where the fundus is not examined poorly, because we don't know what sort of a TRD may be sitting at the back. And other contraindications would be for any kind of surgery, infections in and around the eye, uncontrolled sugar, diabetes, or hypersensitivity to injections. Coming to complications, I'll just skip these. A lot of complications with anti-VEGFs are known. Now, coming to consideration with cataract surgery considerations, we know that there is about 2.6 times higher risk of a PC tear in patients who have taken more than 10 injections. So, patients with repeated anti-VEGF injections, we need to be really careful in doing the cataract surgery. There is going to be some zolunar weakness, and the risk of cataract end-off is also known to be a bit more than normal cataract patients. Surgical techniques, I think, sir explained beautifully that it needs to be a clean surgery with gentle techniques so that there is no inflammation post-op which will worsen the macular edema status. Other than that, it's important to have an adequate rhexis so that patients don't have capsular phimosis post-op, and we'll be able to evaluate the fundus and do a PRP later on if required. Avoid silicone lenses in patients. We plan to do a vitrectomy and put oil. Coming to certain specific indications like DME, inflammation associated with cataract surgery is known to break down the blood-retinal barrier and worsens the DME and DR. Now, according to DRCR .net network, it is known that the risk of developing DME and worsening of visual acuity can happen within 16 weeks of the cataract extraction. About 50% of the previously treated DME patients may have worsening of edema. Therefore, patients with significant cataract significant cataract and DME, we must do the surgery along with an anti-VEGF regime. Knowing that the DME may worsen and the treatment for DME may require to be made more aggressive post-surgery. Among steroids and anti-VEGF, similar sort of outcomes have been seen. Important thing is a prompt retina evaluation and post-operatively, and send to a retina specialist if possible. I'll skip this. All these are basically some studies where anti-VEGFs have been used perioperatively or intraoperatively along with cataract surgery. Coming to wet AMD, now cataract and AMD are a comorbidity in about 74% of visually impaired people above 65 years of age. Here the main issue is the timing of the surgery. There may be progression of geographic atrophy, development of CNV, or weaker anti-VEGF response post-surgery. So according to, I'll just quickly go through a couple of studies. So Anchor and Marina, they studied these patients who were previously being treated with ranibizumab, underwent cataract surgery. All of them had vision improvement up to 2 lines. Now here, according to the Fight Retinal Blindness Project, it was noted that the patients who underwent cataract surgery within 6 months of starting treatment had loss of letters. So it should ideally be avoided within the first 6 months of starting treatment. All sort of anti-VEGFs, like I previously told, have been used, including aflibercept. Here, it was seen that there was no worsening in the macular status or the need for or increase in the frequency of anti-VEGFs after the cataract surgery. And it included patients who were previously stable for at least 2 visits before planning for cataract surgery. This is combined inactive CNVM. So just summarize by saying that combined surgeries do not seem to aggravate the CNVM. Higher mean BCVA is seen with anti-VEGF therapy and cataract surgery. Ideally, anti-VEGF surgery if we are planning, should be given 1 month before, or some studies say even 1 to 2 weeks before is shown good effect. Timing is still debatable. Avoid within the first 6 months of starting treatment, and if the patient has had 2 visits of inactivity, in the cataract surgeries can be safely performed. Frequency of anti-VEGF is likely to remain the same 12 months before or after. So RVO and cataract surgery would behave similar to a diabetic macular edema, so I'll just skip this. In combined cases, we would probably avoid brolucizumab because these are cases where the risk of inflammation would be higher. So to summarize, intravitreal injections combined with cataract improve surgical outcomes. Pre-surgery, a good examination is necessary. Choice of injection depends on the pre-existing conditions and severity of edema and other contraindications. Post-surgery, patients with DME need aggressive treatment and prompt retina evaluation. Timing of a cataract surgery in wet AMD is still debatable, and caution should be advised with newer agents because of lack of data. Thank you.
Dr. Ravi, uh, anyone has any questions to Dr. Monica?
It is not an uncommon occurrence for us to identify DMEs and wet AMDs when the patient comes for a pre-cataract surgery screen. A lot of patients where we see there's subtle edema, there's subtle subretinal fluid with a thin fibrovascular medium. So when do you decide? I mean, do you decide to go ahead with the surgery in these cases? I mean, what is your criteria to treat the macula simultaneously with the cataract, pre-treat the macula and then wait for it to resolve and then go for cataract? How is it that you usually...
So in patients, is it center involving or extrafoveal edema? In extrafoveal edema cases, we can go with cataract surgery. And if it is a significant edema, we would like to treat it before the cataract surgery. In CNVM cases, ideally we should postpone the cataract surgery.
Okay, and there is a significant cataract. Not many proliferations, but except that there are some new vessels which you have identified by doing an FA or by even by clinical examination. How would you treat this patient? Would you get the cataract out first and then do the PRP later on? Or would you combine it with an intravitreal injection with the cataract surgery itself and then... So what would be the way you would be treating?
So that depends on how aggressive the PDR is and how much is the cataract grade. Will I be able to do a laser in a phakic eye? If I would be, I would definitely try and put it at least 1 or 2 sittings of laser before the cataract surgery. And if the macular edema is also there, then provided no tractions, we would prefer giving an anti-VEGF also.
And how long will you wait after the cataracts, means after the laser has been attempted, how long will you wait for the cataract surgery to be done?
It depends. If it is a very visually significant cataract, we could wait for a couple of months also. If it is a cataract, we'll wait for a couple of months. And if it is significant, then maybe another couple of weeks.
So what would be your cutoff for a CMT, a central macular thickness, for giving an injection and not giving an injection and only considering cataract? So the patient doesn't have CME. It is some kind of a spongy thickening, which is ranging at around 290, 280.
No, so it's above 300. I would prefer combined with an
So
anti-VEGF.
300 is your cutoff. And what about patients who have the higher normal range, like above 270s and all, where there is still no cyst?
There would be, if there is spongy thickness, we look at the...
So it is still maintained. So whether, as you suggested, it's 300 means exact 300. If it is 299, you would not inject? That's the question.
It's not. It depends on the. How many cystic spaces are we seeing, or is it really looking edematous or not?
And if you are considering injection in such cases, which would be your priority? 1, 2, 3.
Anti-VEGFs would be my
Whichever,
first.
anti-VEGF, steroid, whichever.
Anti-VEGF would be my first priority. If there is no recent cardiac event or thromboembolic phenomena, I would give anti-VEGF first, because of probably the risk of with orthotics implant.
Mm-hmm. So what we have seen is like it's anti-VEGF usually the level 1 or level 2 ones usually work for around 4 weeks or 6 weeks. But the problem is the macular thickness increases beyond 6 to 8 weeks. So in those cases, whether you prefer, because when you're seeing that, okay, systemic history of probably nephropathy is there, diabetic is controlled, but a long-standing, and the CMT is around 300, so still you would want to prefer the level 1's anti-VEGF, or still you would want to prefer something else which would last for more than 6 weeks to 8 weeks?
100 kind of macular thickness, I think we'll get away with an anti-VEGF and follow up the patient post-op, and if there is worsening, we can then maybe go on to a Ozurdex or something.
Because at this point of time, the chair time, what we discuss with the patient is that expectedly the CMT is going to go worse, and then you would require multiple injections.
So would be probably a
prepping
steroid.
the patient beforehand is very important, or otherwise,
Definitely.
if patient understands, then choosing anti-VEGFs which have a longer duration of action, or either opting for steroids. Or a usually combination is not as a first choice, but that would be my take.
Then we would want a steroid.
A little more towards steroid.
In those cases, definitely we'll plan for an implant or something. Okay, thank you, sir.
Dr. Ravi. Yeah, Dr. Ravi is a faculty at the Minto Regional Ophthalmic Hospital, my dear friend, and a very capable and competent surgeon.
Thank you, sir.
Over to you, sir.
Thank you for the compliments. So good morning, everyone. So I'll be talking on the posterior segment complications after a cataract surgery. So as you all know, cataract surgery is a very safe and an efficient procedure. However, any complication has its own, any surgery has its own complications. So, but it can occur rarely in a best of the best hands. So awareness of these risk factors can enable the surgeon to prepare well in advance and plan for better management of these complications. So what are the posterior segment complications which can occur after a cataract surgery? So it can be an intraoperative or a postoperative. Intraoperative, it can be a needle prick injury because during a anesthesia or an IOL drop or expulsive choroidal hemorrhage. Coming to the postoperative period, it can be retinal detachment, infectious endophthalmitis, cystoid macular edema, and a progression of an already pre-existing retinal disease. So it's important to identify the risk factors so before doing a cataract surgery so that we can prepare well in advance for management of any complications arise during the surgery. So it's important to in eye myopia because its globe is larger and there may be staphyloma, so it can have chances of perforation or penetration during an anesthesia, especially given by a trained residents. Then it's always better to give a peribulbar anesthesia than give it subtenance than a peribulbar anesthesia, which is more safer. So an uncooperative patient, so you don't know when he is going to move his head, so especially hard of hearing, uncooperative. So it's better to consider general anesthesia than a local anesthesia. Post vitrectomy or a posterior polar cataract, where already the dehiscence, or we don't know the status of during the vitrectomy whether lens touch or not, so it can lead to a nucleus drop during a surgery. An eye intraocular and old age, then an uncontrolled hypertension, which is at risk of developing an expulsive choroidal hemorrhage. Of course, a posterior capsular rent, which is a more risk of developing complications during the postoperative period. So coming to the needle prick injuries, it can a simple laceration or a penetrating or a perforating injury. So such cases should be further evaluated if you are able to see the fundus and if there is not much of a bleed or not much of bleed, you can just observe, identify the area of the injury, treat it. So suppose if you are not able to, you are missed any globe perforation or you are not treated because you didn't identify it, so it was not in the posterior pole, so it can present with the retinal detachment later on. Coming to the management of needle stick injuries, elective cases, you should, if you are identified on table before the surgery, it's better to call off the surgery and manage the perforation, then you can schedule later on stage. If only a vitreous hemorrhage without a retinal detachment, you can initially observe the patient for the. So if the vitreous hemorrhage resolves and you clearly see a break, you can treat it with either a laser or a cryo. So if hemorrhage is not resolving in 2 to 3 weeks, it's better to intervene and do a surgery. Coming to the nucleus drop, so nucleus drops usually occur when you fail to recognize a PC rupture in an early stage, or suppose that there was a total cataract and there was already a posterior polar cataract which you are not identified, so it can occur during hydrodissection also. So a gentle hydrodissection is very important. Don't try for advice for a cataract surgeon. Suggestion is don't try to fish out or try to go into the vitreous and try to deliver the nucleus. It's okay. There are a lot of retinal surgeons who can manage the case well, so give it to them. So always secure the main wound. There is a nucleus drop. You secure the main wound, okay, so that it will help in better management during vitrectomy. Timing of surgery depends, but better do as early as possible, preferably the same day. So here is a case of cataract surgery done by a resident post SICS. There is a SICS tunnel with a suture. So he has placed to manage the IOL in the sulcus. So now referred to a retina surgeon. So this it's very important to do port side vitrectomy, especially before inserting your phaco-frag probe, because there can be chance of dialysis near the port. So and PVD is a must before adventuring into nucleus or an IOL management. So here the phaco-frag is being done. In another you have to close because it's a 20 gauge port for a fragmentome. Then another case of an nucleus drop. So following an SICS. So clear all the cortical matter. So it's always it's very important to indent the periphery before closing the case, especially phaco-frag. So lens can be managed in various ways. You can use a PFCL and float it and get into through an SICS tunnel, or you can do a fragmentome, or you can just use a 23 gauge needle and get into the through the AC route. So PFCL is especially for beginners to avoid any iatrogenic breaks. So the iris claw, or you can plan for a second travel at a later date based on the surgeon's preference. So coming to the dislocated new IOL drop. So this is a short video. Again, it's important to do a PVD before any catching an IOL. So PFCL is an important tool. You can use an handshake technique and you can get to the IOL. It's a post vitrectomy eye. You can see the IOL along with an entire complex, back complex. So expulsive choroidal is one of the nightmare for any cataract surgeon. So it's very important to watch out for the warning signs. So you can see there is a sudden change in the glow, so and sudden rise in the intraocular pressure. So AC shallowing. So you should always watch out for it. Even we can see a lot of there is, you can see I have seen few cases where during surgery the expulsive choroid hemorrhage, even I could not help that case. So in then we can imagine a cataract surgery, we cannot see the choroidals happening. So you can see an ultrasound with a, so there are indications where there is a kissing choroidals, suprachoroidal hemorrhage with an RD or vitreous hemorrhage. We need to do surgery. Timing of surgery, usually it's better to wait for at least 10 to 12 days for the clot to lyse. Then we can drain. So here is so you can drain using a scleral cut-down. Usually you do 4 mm behind. So use a 4 mm incision. Use an AC maintainer. We have to increase the intraocular pressure so that it drains. So you can use a trocar system to drain. So AC maintainer. There you can see, visualize the choroidal hemorrhage. In this case, there was no retinal detachment, so it was only a suprachoroidal hemorrhage. So here you can see, using a vent, the hemorrhage is being drained. So coming to retinal detachment, it can occur right in any case of a cataract surgery, even if it is an uneventful surgery also, retinal detachment can occur because of the PVD. So it's important, the surgical management, the method is depend on the surgeons, but usually it's a vitrectomy which is preferred choice. So it also depends on the size of the size and the location of the breaks, what is the extent of the RD, macular status. So this is a case of a post multifocal IOL. You can see there is, sorry, I'm not able to forward the video because now the 240 band tunnel is being made. In this case, there were multiple lattices and break happened at the posterior edge of the lattice. So you can see superiorly there is a lattice with an HST. Injected just to confirm. Usually PVD, there is HST PVD occurs and it helps in better peripheral vitrectomy. PFCL till the break, if you don't want to do drainage retinotomy, then you can. Cystoid macular edema is also one of the important cause. Patient was seeing better and it has patient developed diminution of vision usually after 6 weeks. Various treatment options for macular edema. To summarize, complications are a part and parcel of any surgery. Identifying risk factors and preparing to handle these complications make the surgeons and patients' life better. So don't get panic under promise and over deliver is a better choice. Thank you. Time.
It's okay. Since you are my friend, I'll pardon you for that. But then I would request. I mean, all the topics are quite extensive,
Exactly.
and 6 minutes is not good enough. I understand. Particularly, we retina specialists, we are very good at pointing mistakes in the cataract surgeon. So we have a lot to say. So it's quite natural. So 6 minutes is not enough. I think we'll go ahead with the talks and then come back to the questions again.
Thank you,
Dr.
sir.
Santosh, please. Dr. Santosh is a senior retina consultant at Narayan Netralaya, a very dear friend of mine, passionate about cars and travel.
Thanks.
Very nice man, thorough gentleman, aren't? But yeah, still. Thank you, Dr. Santosh. Please go ahead with your talk.
Thank you, sir. Okay, good morning all. At the outset, I would like to thank BOS for this opportunity. So, little offbeat topic, evaluating unexplained vision loss after cataract surgery. Mostly, we refer it to neurophthalmology in our hospital, but I'll try to make it as interesting as possible. So, there are different terminologies that are used. Initially, historical visual loss and malingering, and these are all the terms. But when we talk about unexplained vision loss, it has to be visual loss or visual symptoms in the absence of any medical detectable eye visual pathway or brain condition, or actually there shouldn't be any identifiable physical cause or at least one inconsistent feature on visual function testing. So this is how the terminology had changed over a period of time through the decades. Initially hysteria was used, later on now it's known as functional visual loss. So now, as of now, functional visual loss and other psychogenic vision losses are the terms that are used. So when you look at the different conditions, again coming to the conversion syndrome, which is a functional neurological syndrome, it has to, the definition is clinical findings are incompatible with the symptoms and recognized neurological or medical conditions. But again, malingering of factitious disorders, wherein there's falsification of symptoms as signs or induction of injury or disease. So to evaluate, it starts from observing the patient when he first enters the clinic. You need to carefully observe the patient's behavior. Usually these patients have exaggerated movements and they keep bumping into objects more than expected. Sunglass sign is what is described, wherein patients tends to wear a sunglass even inside the consultant's room, and handshaking interactions also need to be observed. History and past history also are extremely important, but the main important thing is we shouldn't judge the patient's character just based on the history and other findings. So to start with the evaluation, monocular vision loss, it starts with fogging test, cylinder test, stereoscopic test. I won't go into details of this, and even pupillary response, especially if you have an RAPD, it's obviously very clear that it's either a retinal or a neurological optic nerve related issue. When it comes to binocular visual loss, the first thing is observation. We need to observe the patient again. We kind of proceed with the visual acuity determination from the best corrected visual acuity, and then we go up and then we see what really happens. And proprioceptive tests like fingertip and signature test also make sense. Mirror test and optokinetic drum also. We can see the changes in these patients over these tests and all. So when it comes to unilateral presentation or even a bilateral presentation, the goal of the examination is to demonstrate that the patient can see better than what is actually reported in the symptomatic eye. So again, covering this fogging test, Bagolini glass and prism dissociation. So this is how it is, and these patients usually develop a tunnel vision, which I will come to later. Bilateral presentation is more common, which is around 50 to 80%. It's more difficult to evaluate. A proprioception especially helps, and menace tests and flash tests, these are historic and not very used nowadays. But the most common things what you can use is the optokinetic drum, and we need to see the eye contact. Usually patient doesn't have an eye contact initially, but once we start talking to the patient, they start establishing an eye contact. So this is how the visual field varies in such patients. Usually it's a tubular vision. When you see the vision at suppose 6 meters or 3 meters, you can come closer and see if the patient can appreciate vision better. If you can't appreciate, and if it's a tunnel vision in the periphery and with confrontation, obviously it can be towards a functional visual loss. And Goldman testing, uniocular, it's a tunnel vision. What you see, it's a constriction, severe constriction. There can be spiraling and crossing of isopters here. When you come to binocular testing, If you see in this case, right eye is normal, whereas there's temporal hemianopia. But when you have a binocular testing together, the hemianopia persists. So that's how it is. And upon follow-up visits, these tests can be repeated, and you can see the reversal of pattern. But these tests are suggestive, but not definitive. Automated visual fields have a clover leaf pattern, but again, you need to repeat the manual Goldman test to kind of confirm these things. Further workup, as we all retina people do, OCT and CT, MRI and VEP and ERG, you can miss some subtle findings here, like this is status sequelae of PAM, or early mactal can be missed. This is a pituitary adenoma, or even the metastasis in the brain. So these things have to be ruled out to kind of come to a final conclusion. And again, there are two terminologies wherein there's a Wypov syndrome, which happens very rarely because of advanced glaucoma, which has a prior diagnosis of retinal vein occlusion or elevated post-op IOP, and Snuff syndrome, where there is combined surgery when it's done with cataract and glaucoma. There is factors being post-operative choroidal efficiency, which eventual resolution. So though these are rare conditions, these have to be kept in mind in unexplained visual loss post-cataract surgery. Migraine, again, migraine with aura and basilar migraine have different characteristics. So you can have CNS-related symptoms with basilar migraine. So coming to these predisposing conditions, all these things should be kept in mind, the eye conditions and the precipitating factors here. Comorbidities, which can be prior there, and you need to keep that in mind. And perpetuating factors, when the patient feels disbelieved and medical uncertainty and misdiagnosis. So treatment is mostly explanation of this disorder to the patient, orthoptic therapy and psychiatric counseling. And we need to be very careful when we tell the patient about the partial or no recovery. So Spike's protocol was developed initially by the oncologist to kind of tell the patient, to explain to the patient what really it is about. So we need to start with setting up the interview. The clinician has to be prepared. The perception, then the patient and the attendant should be prepared. An invitation, we need to kind of invite the patient and tell the diagnosis. Knowledge, how much to be told to the patient. Emotions, we need to understand the patient's emotions. You can't tell them completely and directly. And strategy summary, you need to find out whether the patient wants to know everything, whether how much has to be revealed and what has to be done. So again, these are the ways of communication, the naming of the problem. You can use some metaphors to the patient to kind of explain, and you need to talk about the photophobia, providing information, prognosis, orthoptic treatment. So it's a delicate workup that needs to be done, and we need to proceed further. So treatment strategies, we need to optimize the visual input. We need to see whether there is a neurological comorbidities, especially migraine and such things. Then the field test and other tests that needs to be done, and anxiety and photophobia has to be relieved. So to conclude, we should always have a high degree of suspicion. Unreliable tests necessarily do not imply that the symptom is functional. Coexisting ophthalmic or neurological disease, they can have a superimposed variability and decline. So we need to keep in mind that the known psychiatric as well as neurological or ophthalmic disease doesn't necessarily exclude functional visual loss. Thank you so much for the patient listening.
Thank you, Dr. Santosh. After referring it to neuroopthal, if you can speak so extensively, I'm sure how much more you can do. So, yeah, please go ahead. This should be an in-house question, by the way. Yeah. Shrikant, please.
How do you define unexplained vision loss? Because suppose the patient's vision is expected to be 6/6 after cataract surgery, ends up with a 6/9 vision. Does it mean unexplained vision loss? Or if a patient's with myopia, pathological myopia, where your expected vision was 660, ends up with a 3/60.
Thank you, Dr. Santosh. After referring it to neuroopthal, if you can speak so extensively, I'm sure how much more you can do. So, yeah, please go ahead. This should be an in-house question, by the way. Yeah. Shrikant, please.
How do you define unexplained vision loss? Because suppose the patient's vision is expected to be 6/6 after cataract surgery, ends up with a 6/9 vision. Does it mean unexplained vision loss? Or if a patient's with myopia, pathological myopia, where your expected vision was 660, ends up with a 3/60 vision, that's unexplained. So is there a quantification factor where you'll say that it's less than 2 lines than what was expected? Is it, how do you define it? Because we get a lot of cases in our OPD where 6/6 was expected and ends up with 6/9, and they say that it is not correlating to what it is expected.
There's no clear definition in the articles which I went through. They only talk about moderate and severe visual loss. So one thing is if the anatomical and these things really do not correlate with your pathological myopia, things can be expected sometimes. You can prognosticate, but if it's a real drop in vision and there's nothing that kind of correlates with, especially with your anatomical findings, and then obviously you need to kind of go towards this field wherein you need look at functional visual loss.
Are we talking about expected vision loss? I mean, expected low vision, or are we talking about?
We have to have some expected vision post cataract surgery. And if that expected vision is not being met, then only you will have to call it as unexplained vision.
Yeah, theoretically, even 6/9 when you expected 6/6 is unexplained visual loss. Theoretically, yes.
So every cataract surgeon or any surgeon who's advising a surgery, he should have mentally, or he should write it on the file, right? What is the expected vision that he's expecting?
That's okay. I think, Dr. Ramesh, we can leave the things there and probably move on with the next talk. Because see, these things never end. I mean, these kind of discussions never end. It's an ideal situation, yes, where we need to under promise and over deliver, but that doesn't happen. Dr. Srikanth is another leading retina consultant in Bangalore, taking care of Bangalore North, and a lot of diabetics go to him. So welcome, Dr. Srikanth. Please go ahead with your talk.
Thank you for the pleasant introduction. So I'm talking about comparing anti-VEGF molecules for DME and showing a video on a safe technique for the intravitreal injection. It's a basic, I'm just trying to keep it very simple so that we have more discussion. As we all know, 17% of diabetics develop retinopathy, and the diabetic macular edema is up to 10% in various studies. So that is the major chunk of vision loss in diabetic patients, more than diabetic proliferative retinopathy. And given the population of diabetics in India, that translates to almost 15 lakh diabetic macular edemas at present. So with OCT classification, the grading has become quite simple. Either we call it center involving DME when the maximum thickness of the retina is at the fovea, or a non-center involving DME where the retinal edema is concentrated more away from the fovea. And all our injection treatment is based mainly to treat the center involving DME. So if you look at a simple flow chart, the center involving DME, we always start with anti-VEGF injections. It could be either anti-VEGF or a steroid depending on the individual case. And a non-center involving DME, if it's suitable for a laser treatment, we are treating with focal laser. And center involving DME with anti-VEGF treatments, once it is resolved, we leave it at that, or we may do a rescue laser when the center involving part is no longer there. And the important thing is to address the systemic cause promptly. Anti-VEGF, when it was introduced, was the game changer for treatment of retinal disorders. Mainly it binds to the VEGF and thereby reducing the vascular permeability. And as we all know, Accentrix was the first approved drug. And from multiple data, we know that the peak action is by about 1 week, and it works in the eye for about 4 weeks. And over time, we have a huge menu card of anti-VEGF that we can use for treatment of DME, starting from Avastin, which is an off-label pan-VEGF inhibitor, to Accentrix and multiple biosimilars. And with the newer introduction of Eylea and Vabysmo, which Divyansh will speak about later on. So first to come was the VEGF-A inhibitor Accentrix, which is time-tested with a decade of data and impeccable safety profile. And DRCR.net has said that injections, frequent repeated injections, are far superior to laser treatment in terms of DME resolution and eventual visual outcome. And in India, Avastin is the most commonly used, off-label used drug because it's a pan-VEGF inhibitor. Cost is relatively less, but there is a small relative risk of a thromboembolic event, but it's the best bang for your bucks. Biosimilars, yes. Biologic products that are similar to an approved innovator drug, and we have seen quite a few of them now. Which are supposed to be comparable in terms of safety and efficacy to the innovator drug. It's more cost effective when multiple doses are required, and more favorable when retreatments are required. We have biosimilars, ranibizumab biosimilars. I think ranibizumab biosimilars are the more popular now, and aflibercept biosimilar is something that's soon to come. So we have the Raja and the Rani. These are the most popular ones we use. All of us retina specialists, with Razumab being the most popular, with over 10 lakh drugs injections being used in India, and Rani is over a lakh. And there is also Osiva, which is marketed by Sun Pharma, and Reliance, which is marketing Ranizurel. I don't have much personal experience with the last two of them, but I have used quite a few of the Razumab and the Rani eyes. Multiple phase 3 clinical trials have shown no difference in the CMT reduction, or the letter gain, or the number of injections required, or the incidence of adverse events between innovator molecule or the biosimilar drugs. So the choice of drug is left to the discretion of the treating ophthalmologist now. The newer option now we are now looking at more often is aflibercept or Eylea, which is a larger molecule, and compared to the anti-VEGF, this is a recombinant human protein which binds to A, B, and prostaglandin inhibitor as well. The advantage being it works longer, and it's got a stronger inhibition of VEGF induced vascular leakage. So what is the first line of drug that we should be using? From DRCR data, we know that aflibercept over 1 year of treatment gave us a visual gain of 13.3 letters, whereas ranibizumab or all its biosimilars gave us about 11 letters visual gain, and Avastin bevacizumab about 9.7 letters. And from the data also, we know that Eylea seems to work best when patients have got a poor initial vision. And so indications, we all know, all center involving DMEs, or I do use anti-VEGFs in some cases where there is a prior to cataract surgery, even if it's not center involving, or if the media is not clear enough for us to do a laser, or where steroids are contraindicated. The gist of the matter is, start with any biosimilar ranibizumab and 3 loading doses followed by a PRN. And if 2 consecutive 4 weeks apart visits the CFT remains high, then we'll have to look at other alternatives. Eylea seems to be more effective when the visual is poor. I'll just quickly go to the video because we are short on time. So that's my clinic. So more important than doing the injection is discussing and strategizing. We can do the injection in an operation theater or in a separate dedicated injection room. I always recommend that you have a separate set for injection. Don't pick it out from your cataract surgery set. I also advise the patient to apply preoperative antibiotics at home, and I also apply preoperative betadine eye drops to the eye when the patient is getting prepared in the ward. And it comes with a filter needle, all the anti-VEGF vials to draw out the drug, and I apply prep the eye, leave the betadine on the eye while I draw the drug, so that it gives us that extra 30 seconds for the betadine to work on the eye while I draw the drug and prepare my injection. I use a whole towel. I don't use an operating microscope. I feel comfortable with my presbyopic glasses itself. Avoid touching the skin. Use a cotton bud as far as possible. Topical anesthesia only. I don't use anything else. That's a injection marker which I got it made. It gives a fixed measurement of 4 millimeters and 3.5 on the other side. I think these are now available easily. Aim at the midvitreous. I use a 2-hand technique. I stabilize the syringe with one hand. I push the plunger with my other hand. I'm a left-hander, so that's how I do it. I use the cotton bud to kind of block the injection site,
I don't apply betadine. Some people put betadine into the eye at the end of injection. I feel that's not a good practice. I put antibiotic, 1 drop, and that's my technique. That's it. Thank you.
Thank you, Dr. Srikanth. I request Dr. Divyansh, who's a dear friend of mine, uh, upcoming legend, doing great work at Shankara Eye Hospital as a part of the great team that they have, dealing our difficult cases as well. Thank you so much, guys. I request Divyansh to go ahead with the talk.
So, good morning all, and on the outset I want to namaskar all my teachers because today is a Guru Purnima. So, thanks again, and thanks BOS to giving us this opportunity. I would be presenting target angiopoietin 2 and VEGF, biology, pharmacokinetics, and latest clinical data in AMD and DME. So, disclaimer, this presentation is supported by Roche. Ang2 is involved in pathophysiology of multiple diseases like retinal choroidal neovascularization or neovascularization otherwise in the retina also. It is also involving in non-healing venous ulcers, pulmonary fibrosis or interstitial pneumonia, and even with COVID-19. It is also involved in wound repair and scarring in chronic kidney disease and in certain cancers also. So how exactly does it work? So as we can see the first part where we can see that this is the normal usual association where the Ang1 is associated with the Tie2 receptor and the forward signaling is more positive where everything is working as normal as possible. But as soon as there is an oxidative stress and there is angiogenic switch, the Ang2 increases and which displaces the Ang1 and then gets associated with the Tie2 receptor and causes the forward signaling and causes all the negative associations like leukocytic migration and vascular leakage and cytokine associations. So this is one of the studies where they identified whether this blocking of Ang2 would have a positive association alone or with a combination of anti-VEGF. So they could find out that yes, it had a positive association, that anti-VEGF alone is not as good as an association. So in this case, they had tried out is navacizumab, which is at 3 and 6 milligrams, which worked equally well. Whether does if we double the dose of the anti-VEGF, does it work as well? So right now, the studies in AMD, the Harvard trial showed us that 4 times ranibizumab is showing not very significant result as from the primary dosage which we are giving in AMD and as well as in DME. In aflibercept, right now the 8 milligrams trial is still going on. So the 8 milligrams is showing that the response of 2 and 8 milligrams is more so equal in PULSAR and the PHOTON study. So this is the faricimab or the Ang2. So it has an association of both the Ang2 and the VEGF-A part of it, which it blocks both. So they have done an AC tap and then identified whether there is the kind of Ang2 at what proportion it is seen. So BQL is below the level of quantification. So within 1 week, it is so low that it cannot be found out both in AMD and DME. But in cases of aflibercept, it was still found out at that point. How does it work actually is the whole video. So a small kind of a depictive video where it is showing that, is there a sound to it? Sound. So how does it inhibit both the pathways is by working on Ang2 and working on the VEGF. So this is Ang2 and this is a VEGF-A, which it blocks both of them. And as we were discussing, so the Ang2 is associated with the forward signaling and tying onto. Ideally, this is where it has to be, so that the Ang1 gets associated with the Tie2 receptors and decrease all the negative associations of vascular leakage and things like that. And the VEGF decreases the neovascularization and also the vascular leakage within the vessels and increases the vascular stability. This is how the faricimab works, which has both the pathways. So the study was done in DME and AMD. As we can see, yosemite and Ryan were in DME, and Tenaya and Lucerin was done in AMD. So this is the CMT association, which was showing significance beyond 4 weeks of time. This is a 12-week interval which they're showing. As we can see, more than 80% of cases could achieve more than 12 weeks of interval. So more than 12 weeks means 3 months. And as we can see, more than 50% at 1 year was of 4 months, that is 16 weeks. And we can see at 2 years, it is still maintained and it has increased. So as you can see, the 16-week interval has increased from 50 to 60%. So on an average, around 80% is what it can cover, and more than 70% of cases were able to achieve that. The same was in AMD also, as we could see in DME. What are the emerging imaging biomarkers which help in using this kind of molecule? So discussing about AMD, this is the Tenaya and Lucerin. As we can discuss, see over here, the greater anatomical improvement in NAMD, which is showing as BCVA improvement over here, and this is the CMT improvement, which is significant at 4 weeks. This was comparison with aflibercept. So this is a very gross chart to show that when the maximum number of injections had the maximum benefits. In this case, we can see at 8 weeks, the faricimab is showing a very good response, and the number of injections as compared to aflibercept was a little lesser. As we can see, so it's a faster and fewer injection kind of an association. Does it have other positive impacts? So yes, it has a positive impact on max PED thickness decrease also, and it improves in PED outcomes in cases of utilization with AMD. So this is a post ad hoc analysis where the thickness or the max PED association was studied at 12 weeks. So we can see at from 4 weeks onwards, there is a good significant association where the PED decreases pretty significantly. So in DME, let's see about what all things does it impact. So so this is showing as number of injections, and this is the chart or the follow-up of the patients showing as the first one is faricimab, which is utilizing Q8 intervals, and the second one is PTI, which is the personalized interval in the patients. And the last one is with the aflibercept. As you can see, the number of injections are much lesser, and the response starts at around 20 weeks of time. And this is regarding the absence of IRF. So it is not only the macular thickening, it is sometimes the intraretinal fluid and the subretinal fluid. And as we can see, for the IRF also, it has a pretty faster kind of a resolution, and a significant lesser number of injections are required. And this is what it is showing as more than 75% of percentile of injections whosoever has taken were still responding very well, but aflibercept couldn't continue till 100 weeks till that point. Does it show vascular stability? So they had seen regarding leakage. So as in this case, we can see at around baseline at weight 16, most of the cases had very good vascular stability as compared to aflibercept. Does it match to what we had dosing intervals? So most of it is showing that dosing interval at around treat and extend or Q8 equally works well. How does it grossly show is this, it also works in something which is called as in hyperreflective foci, or this is the red dots is kind of an pictorial description or diagrammatic representation of number of hyperreflective foci. As we can see, after the injections are given, the foci have also decreased. So does it really work in comparison to aflibercept? Yes, in most of scenarios, even if we are giving at Q8 interval or Q12 or more than that, it is working very well. Does it also predominantly affect HRFs in outer or inner? So aflibercept does work in the outer, but in this case, it works on both outer and inner association. So what is the conclusion out of this? That it not only decreases the CMT, it also decreases the hyperreflective foci, and it works on both Ang2 and VEGF kind of association. Whether does it have any other associations? So this is one of the part that it decreases the chances of ERM formation, which is studied over here at week 100, that the ERM formation is much lesser. So this is the last slide, the clinical biomarker targeting the dual pathway. So it is targeting both the Ang2 and VEGF, which is targeting the neovascularization and the vascular leakage. The vascular leakage is targeted by the both Ang2 and VEGF. It also targets the inflammation and also the fibrosis. So that's how it works in DME, AMD in resolving the fluid and also decreasing the PED. As we were discussing, it also has a positive impact in decreasing the HRFs and decreasing chances of ERM formation. So it gets a bit better disease control with both having inflammatory pathway also associated with it, and extended durability, which as we could see in the previous studies that it works for at least 12 weeks and most of the cases even 16 weeks. Yeah, thank you.
Thank you, Dr. Divyansh. I would request Dr. Sri Bhargavanatesh to start his talk. Dr. Sri Bhargavanatesh needs no introduction. He's one of the prominent retina specialists, inspiring person. He was one of the famous trio who got into ophthalmology despite probably getting seats anywhere else. And very nice gentleman.
Thanks, Vivek, for the kind introduction, and thanks, BOS, for this opportunity. I am filling in for Dr. Hemant Murthy, actually, who is not available for his due to his busy travel schedule. So this talk is about the use of aflibercept and how we can use that molecule effectively to increase the interval between two injections. So the disclaimer is that this is a sponsored talk from Bayer. So we know that neovascular AMD is a long-term disease that requires consistent treatment to maintain the visual outcome. We all went through the phase where we said 3 or 4 injections will be required, and then we realized no, 10 may not be enough, and then we went on to give 30, 40, 50. There are so many patients who are with us who have crossed half century and probably even nearing a century of injections actually. So now we realize that NAMD, especially the type 1s and the PCVs that we talk about, is not a disease that needs to be tackled in 3 loading doses. And the longer we treat, better probably will be the long-term prognosis for these patients. And unfortunately, these also happen to be bilateral disease. So we need to be very careful, at least in preserving good vision in one of the eyes. I think that should be the goal of the treatment. So how do we achieve this goal? By reducing the discomfort of the patient in all aspects, financially, logistically, and with minimal number of injections is the kind of answer that we all are seeking for. We are yet to find the most ideal molecule, but we are, I think, closer to reaching some of the good goals that we have set ourselves for. So longer we treat will be the time when patient loses faith in us. There will be a fatigue factor, and both doctor and the patients will start to feel that this is something which we can take it easily. That is when things actually go wrong, and that is when the vision starts to go down. Either it's the dry AMD part of the wet AMD with RP atrophy, or when the disease recurrence comes back, the SHREM fibrosis, and then we start losing the vision. So this is where we need to be, we have all learned how to give injections. We have all learned about the disease. Now we need to refine our way of thinking and the way we finally treat the patient. So variation in VEGF suppression time between patient indicates the need for treatment individualization. In the sense, not all the patients of NAMD and PCV behave in a very similar way. There is a characteristic, there is a signature of these molecules. We tend to understand the patient and the periodicity between which the SRF comes back or the CNVM reactivates after the loading doses and the initial 6-7 months passes off. So we'll tend to kind of recognize these patterns, and then we start to reduce the number of injections so that patient goes back home happy, retaining his vision with the least number of injections. So in that aspect, aflibercept is a wonderful molecule. We all know that it suppresses VEGF-A and placental growth factor. Both VEGF receptor 1 and 2 is getting blocked, and it's a very good molecule in terms of the clinical efficacy and also achieving the duration between 2 injections, the increased duration. So mean duration of VEGF suppression with aflibercept is approximately about 71 days plus or minus 20 days. So we are looking at about Q12 and Q16 with this particular molecule, which should be the goal. So how do we treat our patients? We have the proactive approaches where we do the fixed dosing. None of us really follow a fixed dosing the way we do in clinical trials. In clinical trials, even when the patient starts to do well, because the design of the trial itself will be such that we give 12 injections without really looking at the macular status. We record it, but still we'll go ahead with the treatment. So that happens only in clinical trials. So in real life, we come back to the reactive approaches, or we tend to adopt a technique called treat and extend, which is a wonderful technique. So kind of a mix of a treat and extend and a PRN can give us a way forward in treating our patients better. So what happens in treat and extend? We adjust the treatment interval for each, and individually according to the visual acuity and the anatomic response and duration of VEGF suppression, and we inject at a scheduled visit so that patient is aware that they are getting the injection, so they are ready with the money, they are ready with somebody to accompany them, and there is no surprise element. So like this, 6 minutes not happen. Okay, and the reactive approach is we monitor the patient regularly and treat accordingly based on the visual acuity and the anatomic criteria. So what do we mean by visual acuity? Especially in the clinical trials, we look at the 5-letter drop in vision and also an increase by 100 microns. So that's the kind of retreatment criteria for in clinical trials. But in real life, we also look at many other things, like if the patient complains of metamorphopsia, a new onset of hemorrhage, new subretinal fluid or intraretinal fluid, and the vision going down, of course, is a trigger. So treat to target with regular injections until the disease is stabilized. Now, what is a stable disease is $1 million question. So we kind of, with our experience, and for a particular patient, we assume that some amount of subretinal fluid is kind of, we are going to tolerate. We don't tolerate the intraretinal fluid much, but we have more, we pardon the subretinal fluids and the sub-RP fluids. And monitor the response and retreat according to the visual acuity and anatomic criteria. We have other ways of looking at the disease by OCTA, but I think we are not really there yet, where we look at the OCTA and say that, yeah, but macula is dry, but still I go ahead with the injection. I don't think we are really there yet. We still go by the macular dryness for our retreatment criteria. So the traditional treat and extend regimens only the interval extension up to Q12. So this is where we are trying to sneak one more month from the disease duration. So how do we treat and extend generally? We give the injection. For diseases like AMD, we extend by 15 days, give the injection again. For diseases like RVO and DME, probably we can be more generous with up to 4 weeks. So what is the consensus of APVRS in Asia Pacific region? Because of the commute and various other logistics, I think treat and extend is kind of gaining a lot of popularity. And we have these studies, Altair and Aries, I will not go into the details, where they looked at the interval of extension of about 2 weeks and 4 weeks. Surprisingly, both intervals kind of gave us the good anatomical outcome and the visual outcome. There was no significant difference between the two the schedules. But early start of treat and extend versus a late start, of course, had little more number of letters of vision gain. That happens because early start treatment extend means that you have already out of the loading dose and the fixed dose regimen. And late start basically means that you have allowed a larger treatment schedule with fixed dose. And number of injections really did not do too much. It's 12 injections versus mean 13 injections. So I think early start of treat and extend may not be the ideal thing. So we aim for the most optimal clinical outcome for that particular patient, and then we start doing the treat and extend. I think that's the way forward. So these are all the studies, those are all the visual gains with the treat and extend, and the mean number of injections is what we see down. So approximately about 10.4 injections in 2 and 4 weekly. So we can either adopt a 2 weekly interval or a 4th weekly interval to extend. And we extend up to 16 weeks, and then we keep giving the injections every 16 weeks. I think that's the summary we are getting into. So, so how does the clinical trials help us to kind of create this? In the clinical trials, if there is no fluid at all, so then the extension started happening either in 2 weeks or 4th weekly interval. If there is a residual fluid but decreased fluid, then you maintain, in the sense that you maintain the same schedule between. So for example, if you have postponed the injection from January to April, so next injection will be similar from April to count 4 months and get the date. So that is how it is being done. But let us say if the patient comes with a new fluid, then definitely you go back to your previous schedule, and then till the new finding disappears, keep giving the injections at an increased interval. So this is the pictorial representation of intraretinal fluid, subretinal fluid, and sub-RP fluid. As I said, I think we are generous with the sub-RP. We tolerate the subretinal, but we have a strict no-no for a intraretinal fluid. But however, I should say that if it's a degenerative fluid, we'll not chase it. We'll not try to chase the intraretinal fluid to that extent. So nearly 60% of the patients could go up to 12 weekly interval with aflibercept, and good number of them also went on to reach Q16. I think Q16, a 3 injection for a year, it's very easy for us to tell the patient also. So this is the RCT between ARIS and ALTAIR study, and then it was subsequently compared to the ranibizumab injections. There were comparable visual gains and with the treat and extend compared to even fixed dosing. So I think it's a good formula to adopt. So the molecule is good, aflibercept, which has superior visual gains compared to ranibizumab and bevacizumab. Treat and extend as a strategy is very significantly superior to the PRN, and fixed dosing is something is unpractical. I know it's not practical at all in real life, and aflibercept with a treat and extend probably can reach where we can start giving our patients once in 4 months. So this is a few case examples where you can see some. You can see on the picture left, the cursor doesn't move. There is some amount of subretinal fluid, and you can see the PED. And subsequently, 4 months later, the PED still doesn't disappear, but the fluid has disappeared. But because of the presence of the PED, which is pretty high, and I'm afraid that this patient might bleed or there may be RP rip, I went ahead and gave the injection. So this is a patient who is actually on a 4th monthly interval. So this is the second patient who had a little bit of a smaller subretinal fluid. After the injection, PED has actually came down, but the subretinal fluid went up. So this is a patient where actually I will go back to much more stringent. Maybe I'll go back to Q8 kind of an interval schedule. Thank you very much.
Thank you, Dr. Bhargav. Dr. Kumar, sir, please. Dr. Kumar is one of the senior most retinologists of Bangalore and Karnataka. He held the fort for a very, very long time before many of us joined him. We are still learning from him. He has a great sense of humor, multifaceted personality, and you will all realize how good a teacher he is from his forthcoming talk. Over to you, sir. Seems to be a very heavy presentation, sir, taking time to load.
I am heavy.
You have gone down, sir.
At the outset, I would like to thank BOS and Dr. Karthik for including me in this session, and also Dr. Vivek for letting me be a tail-ender to this talk, posterior segment evaluation before cataract surgery. Now, somebody described surgery very aptly and a little cheekily also as controlled trauma under optimal conditions, and that too by appointment. And when this trauma is complicated by postoperative distress in the form of a visual or a dioptric distress, it actually becomes polytrauma with disappointment. And the eyeball is just 1 inch diameter structure, a mere 1 inch diameter structure. And if we don't examine this small structure, I don't think we'll be doing full justice to our designation as ophthalmologists before cataract surgery. So one must avoid an unholy haste in jumping and operating on the cataract despite the scoreboard pressure, if I might use that expression. Already the patient expectations are sky high due to various reasons that are enlisted on that slide. And we are promising emetropia when actually there are so many complex mechanisms involved. And in this scenario, if we don't examine the eye as such and put on blinkers and miss the woods for the trees, then we may land in soup many a time. It's good to have Arjuna's vision of only the fish eye view, if I might call it, but it is always good to have a collateral view of the whole eyeball as such. Why pre-op examination? To put it bluntly, legally speaking, to avoid courting the lockouts. But as men of science and as physicians, we need to look at so many conditions which may take precedence over the cataract itself. So the patient may have something that needs our prior attention. There are some conditions that may worsen post-surgery, either causally or consequentially. Also to recognize certain conditions where our A scan, the ultrasound method may be a little inaccurate and we may have to seek recourse to optical methods. and also to detect macular pathology where certain types of intraocular lenses are a big no-no. All of these things need to be documented. This is very important. What was not documented was not done. And audiovisual recordings also will be will be buttressing our preoperative evaluation. So due diligence in examination is extremely important, and fragmented eye care, which is currently the scheme of things, you know, one person examines, the other person takes down the notes, a third person operates, and a fourth person follows up. These are situations which can lead to missed data. So the dictum before operating on any cataract is to assume that this retina is abnormal unless otherwise proved. Before really we go to the back of the eye, we must listen to the patient's story. A history of sudden visual loss or a nondescript history should raise suspicion. Perusing old medical records, be a good matchmaker, I say. The cataract should be commensurate to the degree of visual loss, and if the pieces of the puzzle are not fitting in, we must not do a force fit and assume that the cataract and live in our own make-believe world. So we must look at how well the pupil constricts, and there's a whole list of things. The eye speaks to us and we must be willing to listen. There is a lot of difference between merely looking and seeing and interpreting things, which is a complex mental activity, actually, analyzing and interpreting the findings. Of course, if we have a patient with this orange-brown deposits on the cataract, that means the patient has an intraocular foreign body that has led to sidrosis. Of course, we don't have the liberty of examining the retina like this lady standing tiptoe on the eyelids and trying to force open a non-dilating pupil. In the absence of such a liberty for us, we must seek recourse to the indirect, use a bright indirect ophthalmoscope, and note down all the findings. Somebody famously said that the patient is the center of the medical universe around which all our works revolve. For us, the macula is the center of the ocular universe. So this is a photograph which shows the patient has a nearly hypermature cataract, but you see the fundus, the disc is seen on the fundus camera. If this is the view that we can get on a fundus camera, you can get much better views with the indirect ophthalmoscope. So I really learned this from Dr. Lingam Gopal when I was there as a fellow. He used to write down a lot of findings in the retina with even this type of a cataract. Honestly, I thought he was making up things. But then I realized that it is possible to look at the retina with greater efforts with indirect. These are more pictures to show that one must really make earnest attempts to look at the fundus. Many times, even granular hard exudates at the macula can be picked up, and these kind of vitreous opacities need to be noted down in the case sheets, and the patient told that the patient may have postoperative floaters, because they will then start complaining that after cataract surgery, their floaters have gotten worse. These are some ancillary tests, and as we go by, I'll try to highlight the importance of each one of these. It is important to look at all the slices of the OCT, and this may be passed off as shallow CSR when in fact the patient has a macular hole. So we should be looking at all the slices of the OCT. These are some of the slippery slopes, as I may call it. In totally mature cataracts, it is very, very important to note, to tell the patient that despite a normal B scan, there may be so many other things at the back of the eye. We will see that later. And if there is any incongruity between the view that we see and the degree of cataract, suspect vitreous hemorrhage. Then in cataract, in myopes, there could be a chorioretinal atrophy at the fovea, which we may not be able to clearly see if the view is not good. And in diabetics, particularly beware of hard exudates and old vitreous hemorrhages. And those are some of the other conditions where we really have to be extremely guarded. So if you have told the patient before operation, then it's really the patient's problem. But if you try to bring in an excuse, it will be seen as an excuse if you start explaining post-operatively and you have not done that pre-operatively. Host of conditions I was referring to which can give us a post-operative surprise despite a normal B scan. The list can be a really huge one. The other important thing is to be able to look at the fundi with greater detail, with greater attention, because this patient had a little sheathing over there, and this was the ancestor of these photographs. So subtle sheathing which may indicate an old vein occlusion should not be missed when the view is a little suboptimal due to the cataract. Of course, we shouldn't be missing these occur membrane inferior vitreous hemorrhages. If the patient has a clear view of the posterior pole, always look inferiorly to look for any traces of old vitreous hemorrhage, which may indicate old vitreous hemorrhage due to PDR. I also tend to use fluorescein angiography many times, because to explain an unexplained vitreous hemorrhage when the patient is referred for a fundus view and the opinion, and these kind of subtle vitreous hemorrhages, particularly when unilateral, the fluorescein angiography throws up information regarding the status of the diabetic retinopathy in these patients. The contralateral eye, of course, as I said, as I alluded to in the beginning, will give us a lot of information in these kinds of patients. The right method of magnification and illumination also is very important. If you look at this optic disc, it doesn't look particularly abnormal, but if you just magnify and see, the neovascularization on the disc is staring at us. So these are some of the things that we should be employing in our preoperative examination methods, particularly when there is a reasonably good view of the fundus. And a little particular anterior offset of our view will also highlight the neovascularization on the disc many times. I was referring to OCT. We see the human eye is incapable of finding out many of these conditions. This is the fovea, which clinically looked absolutely normal to me. This was the other eye, operated elsewhere for a macular hole, and this eye has this vitreofoveal traction. Another patient with myopia, where we thought this right eye was amblyopic because the degree of myopia was greater, but lo and behold, the left eye had an ERM with a small intraretinal fluid. This could be due to an old tributary vein occlusion as well. More examples to show that OCT has become an indispensable part of the preoperative workup of patients before cataract surgery. Again, the macula may look rather nondescript, but many of these patients may have OCT. So these are again indications to show that OCT should be an integral part of preoperative workup of all patients. I will end with this patient. This patient I had seen some 8 to 9 years ago, and this was the cataract. The patient was referred for a fundus opinion, and I told the patient that the fundus is normal, and I was writing out a letter. But the lady kept on asking me, "Sir, are you sure is it normal? Is it normal?" Too many loaded questions. Then I put on a brighter indirect ophthalmoscope and saw, but I couldn't identify anything at all. It was just a little epiretinal proliferation-like thing which was causing slight epiretinal folds in the inferior view that told me that the patient had an extremely shallow retinal detachment due to a peripheral break, and we managed to settle that retina preoperatively. So many times, if the patient is asking you a loaded question, "Are you sure it is normal?" you must go back and then review. So which I have learned that after this case. So in conclusion, it is not good for us to remain a mere cataract smith. We are not, the decree from society is not to remain as an artisan or a craftsman. By all means, you be a good artisan. But the decree is, in addition to being a good artisan, we must breathe life into that eye and not say that my surgery is flawless and therefore faultless. That argument will not hold water. And one day, artificial intelligence may come to our rescue in diagnosing whether this fundus is normal or not. But till such time, we should use our innate intelligence and follow some of the steps that we just now discussed. Thank you very much for your patient hearing.
Thank you, Dr. Kumar. I would request our panelists, Dr. Pradeep, Dr. Bhishma, and Dr. Karthik, if final comments to each for the sake of time.
All topics are well covered by the esteemed speakers. One thing I want to add is, if you are planning a combined cataract surgery with vitrectomy, at the end of, sometimes you might have to put sutures if in special scenarios, if you are planning the belt buckle at the same time. And I would prefer before doing the cataract surgery so that we can avoid the IOL prolapse, all those complications. And that's the thing. And one more thing is expulsive choroidal hemorrhage. First thing, cataract surgeons, they have to close the wound as early as possible, not maneuvering much inside the AC. If they can't put through a 9-0 or 10-0, it's better to put a 6-0 or 5-0 also. First primary thing is wound closure, then we can manage later once the clot lysis and all comes down.
Thank you, Dr. Pradeep.
Nothing much to add. I think everything is covered in the sessions.
Thank you, Dr. Bhishma.
Nothing much, sir. I think during the thing we had a good discussion. So we're done.
About the point of Dr. Vivek.
Yes, sir.
Which anti-VEGF or which drug to use on a macula. I just wanted to say that in the surgical parlance, they say you can put anything on a bed sore except the patient. So similarly, you can put anything on an inflamed or an edematous macula except more inflammation after cataract surgeries. You recognize that there is edema, and then you can put anything in there and do an atraumatic cataract surgery. That's it.
Yeah, thank you so much, speakers, coming early on a Sunday morning, foregoing your sleep and all that. And I request all the speakers and the panelists for a photograph. Thank you so much. Thank you, BOS Scientific Committee. Can someone take a good photograph?